Okay, everyone, welcome to tonight's webinar series called Rethinking Osteoarthritis. I'm going to be your moderator tonight. My name is Angela Laborde. I am a arthritis patient myself, and I volunteer with the Arthritis Foundation. I live with psoriatic arthritis, so a little bit different type of arthritis than we're talking about tonight, but they have a lot of similarities. I currently volunteer as a facilitator for our National Connect group for psoriatic arthritis. Something that is very important to me is making sure that arthritis patients have community and can connect with one another, and also are able to have educational opportunities to learn about their own conditions, their treatment, and just to be empowered with knowledge and resources. So I'm really excited to be here with you guys tonight. We've got a really good program with some really great speakers, and so we're going to move along and keep talking about that. So a few housekeeping things for tonight's program is all of our attendees have been muted. Please use the Q&A function. You'll see that at the bottom of your Zoom screen to type in any questions you have. So we'll have a short presentation followed by some discussion from our two experts, and then we'll be ending with a Q&A from the audience. So the Q&A that you guys are typing in, we will circle back to a lot of those questions, and some of them will be answered during the presentation. You'll also receive a post-event survey on tonight's webinar, so we really encourage and hope that you will fill that out for us. You'll also be able to watch this program afterwards or any other of the webinars that the Arthritis Foundation has by going to youtube.com/Arthritis Foundation or arthritis.org, where you can kind of search through our past and upcoming webinars. So a few things that we're going to do here is we're going to talk about our poll, which is how would you describe your current outlook on managing your arthritis, your osteoarthritis? So as someone who doesn't currently have osteoarthritis, this is not one that I could answer in that same way, but I could answer this similarly about, the arthritis that I do have. So please go ahead and answer as best as you feel you can. We'll give you guys a little bit of time to do that right now. Okay. All right, here, so we have, we can kind of see the results here. The majority of folks feel optimistic, but still face challenges. And I think that's a very common experience that we feel with arthritis, right? So, we're going to talk about that tonight. All right, so our webinar experts tonight who are so wonderful and gracious to join us, we have Dr. Kim Templeton, who is a professor of orthopedic surgery and sports medicine with special interests in research in sex and gender health, medical education, and women physician issues. And we also have Dr. Amanda Nelson, who is a professor of medicine and epidemiology, specializing in epidemiology, machine learning, osteoarthritis, and inflammatory arthritis. So some of our learning objectives tonight are, we want to first enhance our understanding of early diagnosis and management strategies to improve patient outcomes, right? We want to make sure that people, are able to get diagnosed and early in the process before things get too bad and learn management strategies to do that. We also want to address disparities by discussing the racial and gender differences in osteoarthritis prevalence and in treatment. Another objective is that we want to examine the impact of sex on osteoarthritis by delving into the rapid progression in women in post-traumatic osteoarthritis. And then ultimately, we also want to equip all of our attendees tonight with tools, research findings, and resources to optimize patient care so that we can foster a more holistic approach to managing osteoarthritis. And with that, I'm going to turn it over to Dr. Amanda Nelson, who's going to, take it from here and explain some factors we've got going on here. Dr. Nelson?
Right. Thanks so much, Angela, and thanks to the Arthritis Foundation and Osteoarthritis Action Alliance for organizing this. and really for all of you for joining. So many people right before the holidays and in the evening, and we know that you have a lot of demands on your time, so we're glad to provide some information, and hopefully this is useful for everyone. So these are some sort of common myths or thoughts that people have in their heads about osteoarthritis that we just want to kind of dispel early here. So one that I hear a lot is that osteoarthritis is inevitable, right? It's just part of aging. It's just what happens as we get older. And that's really not the case. There are changes in the joints that accompany aging, and aging is a risk factor for osteoarthritis, but the two are not one and the same. So people can certainly age without getting OA. Young people can get osteoarthritis, particularly post-traumatic, but also sort of what we might call garden variety. And osteoarthritis is much more complex than just wear and tear. So we often hear, this is wear and tear arthritis, this is old age arthritis, degenerative arthritis, which I also don't like. Those all sort of imply that it's just wearing down, right? Which again is this idea that it's all just aging and damage, and that's not really the case. So we'll talk about the aspects of the joint that are affected by osteoarthritis and how there is a lot more complexity going on within the joint disease itself than we often think about. And hopefully everyone will come away from this understanding that OA is really much more complex than just wear and tear, and that it can affect a variety of joints across ages, and that there certainly are things that we can do about OA, which is another myth that there's nothing to do because it's just this sort of consequence of aging, and that's we have some things to talk about. So next slide. So osteoarthritis, again, is not this wear and tear degenerative process. It's actually a very complex joint disease that's characterized by the breakdown of a variety of tissues in the joint. Cartilage is the one we often think of. So the cartilage thins with age, but it gets really kind of broken down and damaged with osteoarthritis. It also affects the bone. So the bone underneath the cartilage in an osteoarthritic joint is different than healthy bone. The meniscus in a joint like the knee is a thicker sort of cartilaginous pad that cushions that joint, and that can get damaged in osteoarthritis. It also affects tendon and muscle and ligaments and all the other tissues around the joint, including the synovium, which is the lining of the joint that we often only think of in, rheumatoid arthritis and psoriatic arthritis and some of the more inflammatory types of arthritis. Osteoarthritis has been around for a long time. So there's some really cool pathology studies of ancient skeletons looking at the bony changes, right? So you can actually see them in preserved skeletons. It was really kind of named in the 1800s. There's a lot of confusion about what was meant in some of those early descriptions because they kind of conglomerated gout and RA and rheumatism and OA, but certainly has been around for a long time. And then, more recently, and something we'll talk about in some later slides, is this factor of inflammation that's really important in osteoarthritis. Again, this idea of wear and tear and aging arthritis sort of led us away from it being inflammatory. And people would say, well, this is the non-inflammatory kind of arthritis. And that's also not true. It's just not as dramatically inflammatory as something like gout or really out of control rheumatoid arthritis, but it's still got a low level of inflammation, and that's got a really important role in how the arthritis affects us. And in general, we can think of osteoarthritis more as an imbalance of things. So there's too much of the kinds of things that want to build bone, right? So we get bone spurs and bony enlargement, and there's not enough things to keep the cartilage healthy. So the cartilage kind of breaks down and gets damaged. So it's really an imbalance of these things that build up and break down tissues. We can go to the next slide. Think about all the different things inside a joint. This is a knee, but this is true for any joint except for meniscus, which is kind of a special thing. But you can kind of see here where all the different tissues are outlined. So the cartilage is really right along the bony surface. Then the meniscus is sort of between the two bones. We have ligaments and tendons. You see how all these things are really tightly packed in the joint. The infrapatellar fat pad has been implicated more recently in some of the early changes of osteoarthritis. You can see the patellofemoral joint here. So we think about the main knee joint a lot, but less so about the joint behind the kneecap, which is affected by exactly the same changes. And this is a picture from a really nice review that sort of shows you healthy tissues on the left and how the damage manifests on the right. So you see the kind of the wearing away of the cartilage. The bone then is exposed and gets damaged through weight bearing. There's inflammation of the synovium. There's damage to the meniscus, and we start to see those bone spurs or development of additional bone osteophytes that are pointed out. And osteoarthritis is quite common, and it's actually a leading cause of disability. This says elderly adults. I might say older adults. So really, the age is becoming less as we experience kind of the aging and obesity epidemics in the United States. And we can go to the next slide. This is just to give a sense of sort of where a joint might be along the path in osteoarthritis. And it's not linear. So, a joint might stay at kind of doubtful, early, little bit of disease for a really, really long time. And it may progress quickly or it may not progress at all. So there's not sort of a straight line here, but in general, there's sort of a stage where there's really minimal damage to the joint. It can still be quite painful, but if we image that joint, it might look fairly normal. And then it sort of progresses over time to where we get more bone spurs, more damage to the cartilage. Maybe the symptoms get worse. Again, not necessarily in conjunction. So you can have really bad symptoms and not very much change on imaging or vice versa. And then eventually at the end, you get what some people will call bone on bone, which basically means that the cartilage and the meniscus have sort of come out of the joint and been worn away to the point that the bones are touching, which can be very painful and certainly limits range of motion, right? Because we've lost all the cushioning and padding within the joint that really helps it to work the way that it's supposed to work. And that's what bone on bone means. And Dr. Templeton will talk about that in her part when it gets to surgery. But again, this is not a straight through, everybody does it this way kind of thing, but just to give a sense of how it sort of progresses over time. And next slide. This is one I like that sort of summarizes a variety of different management strategies for osteoarthritis. So if you kind of look at, one guideline versus another, you'll see some differences, but this a lot of these are very much four major societies that produce guidelines for osteoarthritis management: the American College of Rheumatology, or ACR, its European counterpart, EULAR. AAOS is the Orthopedic Society, and ORSI is the Osteoarthritis Research Society International. So these are US, European, international, kind of all kinds of different groups of people, varieties of different types of experts. And really everybody across the board recommends weight loss for those who are overweight or obese. So green dots mean, everybody says yes. There's a little bit less evidence for the hip, but across for the knee, we can see that. The other things that are widely agreed upon are self-management and education. You're all doing this right now. So we're going to talk about education. We'll later get to some self-management. But a lot of this is really understanding what osteoarthritis is and what osteoarthritis is not. And that's hopefully what we'll give you some sense of today. And then the third one that everyone agrees upon here is physical activity. This says exercise. Activity might be a little more general. Certainly some purposeful movement is important. It doesn't have to be going to the gym. It doesn't have to be, learning how to jog and doing 5Ks. It might just be walking a little bit more or standing a little bit more for someone who's very sedentary. So it's really more of an increase from baseline activity. Yes, there are some areas down below here where we see less agreement in the yellow and the red. There is some evidence for those things as well. But if we just focus on the ones where everyone kind of agrees these are important, that's a really good place to start. And we can go to the next slide. Now we're going to talk about one of my favorite things and my most focused on research topics, which is multi-joint OA. And we can go to the next slide. I've shown you some things about knee OA, but again, this really applies across the board. So multiple joint OA is just what it sounds like. It's osteoarthritis in more than one joint. It might be both knees and a hip, or a knee and a hip, but it also might be the spine. The foot and ankle are pretty commonly involved, hands, as many of you will know. And it can it can be weight-bearing, but also non-weight-bearing joints. So there are joints in the hand, like the thumb joint, that actually is kind of a weight-bearing joint. It has a lot of force on it, but the finger joints are less so. So it's not necessarily all related to pressure on the joints. It's about use of the joints. Multiple joint OA, like regular OA or single joint OA, is more common in women. And if you think about it, it makes perfect sense that if you have more than one joint involved, you may have worse outcomes and more limitations physically. And that's been shown in some of our work and some of others. And there's probably a higher risk of disability, again, just because you're having this in more than one joint. And we can go to the next slide. Risk factors are across the board, but they vary a little bit by which joint we're in. So we talked about aging already. It is an important risk factor, but it's not one and the same. And that sort of thinning of cartilage that does come with aging can exacerbate the problem with osteoarthritis. So if it's thinning and sort of breaking apart and being damaged, then that is more of a problem than just the natural aging thinning process. A joint injury, like an ACL tear, which people get in soccer and football and other activities, the anterior cruciate ligament is a common one that can lead to osteoarthritis, but this is a lot of different injuries. A meniscal tear, fractures, different things can increase the risk of osteoarthritis in that joint. And also the altered weight bearing from an injured joint can lead to osteoarthritis in other joints. We talked a little bit about excess weight. There's two parts about obesity and overweight that can lead to osteoarthritis or make it worse. One of those is just the burden of the extra weight on the joint. So that joint is having to carry around more weight than it was perhaps built to do. But obesity also contributes to a low-grade systemic inflammation, which is why it's associated with so many other comorbid conditions. And that low-grade inflammation can contribute to osteoarthritis as well. So just losing the weight doesn't necessarily mean that you obviate all the potential risk, but it is helpful, and that's why it's so widely recommended. And finally, genetics. There are reasons why some people get any kind of arthritis versus others. We don't necessarily understand all of those, but osteoarthritis certainly has a genetic risk with it that you can see running in families. Next slide. One of the things that the AF kind of wanted me to bring up, I run a large, diverse cohort study and that's been going on, not personally with me, but has been going on for more than 30 years. And we've really been interested in looking at racial differences. So a lot of studies, just in general, clinical trials, observational studies, are often primarily white in nature, and in other conditions are often primarily male because of the female preponderance in osteoarthritis. We often have more women, but usually fewer Black and Hispanic individuals. And so when we do include other race and ethnic groups in osteoarthritis studies, we find that those minority groups tend to have more pain. Our study has also found that African American and Black individuals tend to have more osteophytes and more knee OA in particular, and also different patterns of multi-joint OA, so less hand, more spine, etc. So there really are differences, and it points out the need to include all kinds of people that might be affected by osteoarthritis, which is pretty much everyone, in studies where we try to understand how this affects people. And yeah. And the little subnote here is that very few people get the proper counseling, right? I think there was a question about PT that we'll get to later, but even just talking about physical activity like we're doing right now is more than sometimes happens. So we really need to push some of those core management features, losing weight, being more physically active, and getting some education and self-management as the sort of basis of management of osteoarthritis. Next slide. And why does this happen? And there's been a lot of theories, a lot of different studies. Race obviously a social construct and has a long history and problematic issues in medicine. And it's probably a variety of things. There may be genetic things going on. There are also obviously some socioeconomic issues and social determinants of health. environmental exposures or different cultural, like nutritional things, diet-based things, and then even the joint pathology and genetics may vary a bit. And all of this comes together. So if we think of the whole person and their osteoarthritis, it's really made up of all of these factors and their overall burden of osteoarthritis, and not just one knee or one finger that might be giving that patient a problem that day. Next slide. So back to some guidelines. This is more focused on the ACR, so the American College of Rheumatology. We talked a little bit about exercise. Again, just avoiding sedentary behavior. So very prolonged sitting is poor for your health, kind of no matter what you look at, right? It's not good for diabetes. It's not good for cardiovascular disease. It's not good for weight, and it leads to excess mortality. So anything we can do to move more is useful and effective, and it actually does improve pain modestly. Right. There are a variety of ways to do this. Walking is easy and safe and pretty effective in most of the studies that have looked at it, and most people can do that, although there certainly are some limitations in having safe spaces to walk and things like that. There are also other things people can do. So yoga is nice. It's sort of a slow movement, gets range of motion going. There are a couple of studies that show really good benefit from Tai Chi. Swimming is nice if people have issues with weight or maybe multiple joints that are involved in their limbs, weight-bearing joints. Sometimes doing aquatic exercise is really helpful. We talked a little bit about weight loss. There are more and more ways to try to help people lose weight every day, it seems like. But obviously the baseline for that is still a healthy diet and reducing calories, and again, being a little more active. Over-the-counter medications, I just want to mention, certainly non-steroidal anti-inflammatories, so things like ibuprofen or naproxen can be helpful, but many people with osteoarthritis have a variety of comorbidities that may make these unsafe. So we always want to use topical when we're able to versus oral, and we want to try to use the lowest dose for the shortest amount of time that we can. So we don't want to be taking maximum dose, NSAIDs every day for months, weeks, and years, because we really can get into a lot of trouble with GI, kidney side effects, other things that are not what we want to do. So using those with caution and with the guidance of your healthcare professional. And finally, some assistive devices, canes, not necessarily walkers, but canes and braces and orthotics and things like that can help with the biomechanics that are altered in osteoarthritis. And PT and also occupational therapy, which is sometimes overlooked, can be very helpful in both advising about those things, but also giving advice about physical activity and different things that people can do to reduce their symptoms. OT is particularly important for hand OA, but can be useful for a variety of joint sites. Next slide. Again, with weight, I know, we all know that not everyone with osteoarthritis is overweight or obese, but it is a major risk factor, and more of our population is living with overweight and obesity, so this is becoming a bigger problem. We know that weight gain, so adding additional weight, can increase the risk of osteoarthritis as well as the symptoms of osteoarthritis and its progression over time. Therefore, obviously, the disability. If we can lose weight, even 5% of body weight, we can decrease those things, particularly joint and body pain, and also allow more physical activity and other beneficial lifestyle changes to happen without so much pain. And again, talking to your doctor is really important because everybody's situation is different. Next slide. I guess this is a question for me. So a key takeaway, I think, really about being empowered is to understand what it is and what it isn't. And to, take this to your doctor, tell them that you're having these symptoms. A lot of times osteoarthritis, people will live with this for years, decades even, before they really bring it to their doctor. And then they've missed out on the opportunity to do some of those more conservative management kinds of things. So get that education, discuss with your healthcare professional, and there are things that can be done for osteoarthritis. Remember if that's the last one. Yeah, thank you.
Thank you, Dr. Nelson. So now we're going to move on to our other speaker, Dr. Ken Templeton. When we think about osteoarthritis, we often focus on joint pain, but as Dr. Templeton is going to show us, OA affects overall health in ways that go beyond joints, making it more than just a localized condition. So with that, going to welcome Dr. Templeton.
Thank you so much. And I appreciate the opportunity to speak this evening. And Dr. Nelson, that was a great presentation. Some of the other things that we'll be talking about too are the sex and gender differences in osteoarthritis. Both sex and gender impact the risks for OA and how you live with OA and some of the issues with pain that they can experience. Sex is the biologic construct, whereas gender is a social construct. Both sex and gender impact the pain experience that you can have if you have osteoarthritis, but sex in particular impacts the risk of developing osteoarthritis. Osteoarthritis, as Dr. Nelson mentioned, is more common among women than men at every age and at every joint, especially at the knee and the bottom of the thumb. Those seem to be the two where there's actually the greatest difference between women and men. We'll be talking some about why these differences exist, but again, it's also the issues with how sex and gender impact the pain that you notice with osteoarthritis. As Dr. Nelson mentioned, the multi-joint osteoarthritis is more common among women. It's not only more common, but arthritis tends to progress more rapidly in women than it does in men. And so, as she mentioned, you may not have mentioned or may not have been asked by your healthcare professional about whether or not you have pain in your joints. Unfortunately, in women, this can progress rapidly enough that this is often missed, and we miss some of the early opportunities for non-surgical interventions. Next slide. So why are there differences between women and men in developing osteoarthritis? Well, there are a variety of things that have been identified. The more we understand about why osteoarthritis happens and what osteoarthritis is, including differences between women and men, the more hopefully that we can start looking at not only early intervention measures, but ideally prevention measures at some point. And we can't prevent something unless we know why it's happening. And so if you look at differences between women and men, there are significant ones that lead to osteoarthritis and increase the risk of developing osteoarthritis. One is joint anatomy or an entire extremity anatomy, especially looking at the legs or the lower extremities. How those are aligned are different in women than in men. How the muscles function are different. So they place different stressors on someone's hips and especially their knees. And we think that increase is one of the reasons that women have an increased risk of arthritis. Muscle strength can also impact the risk for osteoarthritis. Muscles, when they contract, not only help your joints move, but when they contract, they actually provide cushion and protection from the joint. So the stronger your muscles are, the less you're going to put load on your joint with day-to-day activities like walking. And so, as Dr. Nelson mentioned, physical activity, physical therapy, all of these are great modalities to address osteoarthritis, but also likely good prevention measures. The stronger our muscles are, the more they're going to help offload the joint and the less stress you put on the lining tissue or the cartilage of the joint. And so ideally, that would be one way to help address arthritis early. But we know that these differences are greater in women than in men. If you look at women with arthritis, they're much more likely to have less muscle mass than do men with arthritis. There are influences of hormones, especially sex hormones, especially estrogen. Estrogen probably has multiple impacts in the joint. Estrogen does help to modulate inflammation. And as Dr. Nelson mentioned, osteoarthritis is an inflammatory condition. And so the presence of estrogen may help decrease that inflammation. But we also know that the lining tissue in the joint, both the synovium that produces the fluid in the joint and the cartilage, the lining tissue of the joint, the support of the joint, respond to estrogen. And so those likely help protect cartilage, which may be one reason why we see an increased risk of osteoarthritis in women after menopause. When those levels of estrogen go down, that may then provide less protection to the joint. Bone also responds to estrogen. And so with loss of estrogen, the bone that's immediately underneath the joint may become somewhat weaker, and that may also provide less support for the joint. As was mentioned, obesity is a risk factor for developing osteoarthritis, probably for two factors. One, because there's likely a common inflammatory link between obesity and osteoarthritis. So it's in part an inflammatory issue, but it's also because the greater the weight, the more stress you're putting on joints. But interestingly, if you compare women and men, the impact of obesity on the development of osteoarthritis is more significant in women than it is in men. Women tend to have a heightened inflammatory system compared to men, so that may be part of the issue. But for a given weight, a woman is more likely to have osteoarthritis than is a man. And was mentioned also, genetics also plays a significant role in this. Next slide, please. And as we know, pain is one of the primary complaints that someone with osteoarthritis has, in addition to limitations in activity and stiffness and issues with mobility. But there are both sex and gender differences in pain. Pain is not perceived equally among everyone. Pain also is very challenging because it's not like pulse or blood pressure where you have an objective measure where we can measure how much, what your blood pressure is, what your pulse is. We don't have a way to measure pain. When you go to see your healthcare professional, you're often asked to provide a pain score, but that's not really objective. That's something that's based on your prior experiences with pain and how you perceive your pain. And so pain is extremely challenging to try to study and challenging to try to measure and try to follow. But what we know from the literature is that there are differences, again, between women and men in pain. There are basic differences in how your spinal cord and your brain perceive a specific painful stimulus. You even see this in neonates that are in the hospital that have necessary painful procedures, how the boys and girls' brains respond to those painful stimuli are different. So we know that there is a hardwired difference between males and females in how a painful stimulus like osteoarthritis is perceived. And there have been a lot of studies to try to help decipher why that happens. There have also been a lot of studies where they put women and men in a lab and they expose them to painful stimuli like heat or pressure or something like that. Those studies are really hard to interpret because they're usually young, healthy volunteers that don't have an experience with pain. So again, when they say they hurt, it's hard to know how to extrapolate that to someone who is older, who has osteoarthritis or another painful condition. So it's hard to know what to do with those studies. But again, we do know from a basic science perspective that there is a difference in how males and females process pain. But there are also differences based on gender or the biologic construct. It may be more permissible for women to complain of pain or not. Women are less likely to seek health care than are men because from a gender perspective, we're busy taking care of everyone else. And so there may be a difference in how and when women present with pain. There are also issues with self-efficacy, so our feeling of our ability to help manage our own pain and our own health conditions. The higher our level of self-efficacy, or the higher the level that we feel that we can help control our own symptoms, the lower our levels of pain. So that is a gendered influence. That's not something that's hardwired. It's something that can be learned and adapted. There are also issues with what's called pain catastrophizing, where all we can think about is our pain. We're worried about our pain. We're not sure that our pain will ever be controlled. The more we catastrophize about pain and ruminate on pain, actually the higher the levels of experienced pain, and actually the more people seek opioids for pain relief. And so those are gendered influences in which we can actually have some impact on things like you're doing tonight and learning more about a condition in ways that you can help manage it on your own and in collaboration with your healthcare professional. Next slide, please. So again, hormones, especially sex hormones, especially estrogen, have an influence on osteoarthritis. So this is one of many reasons why osteoarthritis is more common after menopause, although certainly people younger can develop osteoarthritis. It's an issue both with control of the inflammatory response, as well as how well the bone and the cartilage of the joint is supported by the presence of estrogen. Next slide, please. Men tend to have experience less pain with arthritis, or at least complain about it less, even with similar levels of joint damage. Less likely to seek care. They tend to have more arthritis in their spine and weight-bearing joints like the hips, and this may be due to different levels of activity. Arthritis in men tends to progress slower than it does in women. And men tend to have greater muscle strength, so that in and of itself may be a protective factor as the muscles again contract and help protect the joints. Next slide, please. But as was mentioned at the beginning, osteoarthritis is more than a painful joint or stiffness or difficulty in function. There is a significant impact on overall health from having osteoarthritis. People with osteoarthritis are more likely to have conditions such as hypertension or other issues with cardiovascular health, depression, and chronic obstructive pulmonary disease. Interestingly, though, although both women and men with OA are more likely to have other health conditions, women are more likely to have each one of these conditions, and they're more likely to have multiple conditions. So, but the thing that we don't understand completely at this point is what is the link between OA and these other conditions? It may be reduced mobility, so you can't exercise or you can't participate with physical or occupational therapy, so you aren't able to help protect your joints. But it also may be an inflammatory component. There may be a common inflammatory component, especially in cardiovascular disease, between that disease and osteoarthritis. So there may be a common inflammatory link, which if we could understand that, we would then be able to improve not only joint health, but also ideally cardiovascular health. So there is a higher risk of cardiovascular disease. There's also, especially in women, a higher rate of cardiovascular mortality. So dying from cardiovascular disease, especially for people that have osteoarthritis of the knee, that's symptomatic, not just seen on x-ray. So if you have symptomatic, so painful osteoarthritis of the knee, your risk of having cardiovascular disease and potentially dying from cardiovascular disease is much higher than someone that doesn't have painful osteoarthritis of the knee. Other risks, increased risk of falls, especially if you have joint stiffness. It's easier to lose your balance. As I mentioned, increased risk of depression and anxiety, and increased healthcare costs, and reduced productivity for those people that are still working that have osteoarthritis. Significant risk of needing to take time off of work, but also reduce productivity at home. So you're just not able to keep up. So it's, again, OA isn't only these having very painful and stiff joints, but its impact on multiple other health conditions, as well as quality of life and ability to do what you want to do during the course of the day. Next slide, please. So when is surgery the answer? And I would say surgery is the answer when someone tells us this is what they want to have done. I not infrequently have patients that will come to see me with osteoarthritis and ask, should I have my joint replaced? Should I have surgery? And that's really not a question that your healthcare professional can answer, because you're the one who knows best how much pain you're in, how much this is impacting your quality of life, what other things you've done to help manage your OA. When those things aren't working anymore, or when you have significant impact on quality of life, that's when it's ready. And when you're ready for surgery, and that's when it's time for surgery. And people will know when it's time to have surgery. I'll tell people that, and they don't know it until they get there. You will know when it's time to have surgery. Next slide, please. So surgery for this, especially for older adults, is what's called arthroplasty, so it's replacing the joint. What hurts with arthritis is inflammation, and when the raw surfaces of the bone are rubbing up against each other. And so what arthroplasty, or joint replacement surgery, does is to remove that lining cartilage, or what's left of it, and replace it with metal and plastic. It's usually two pieces of metal on one side, metal on the other side, and then some plastic in between. And that then helps get rid of the pain from arthritis, because you're not having those raw surfaces of bone or raw cartilage rubbing up against each other. So it's usually used for hips and knees and shoulders, but we can really replace at this point any joint that's arthritic with some type of arthroplasty. So why consider surgery? Again, if you have pain that limits daily activities, and it depends on what your daily activities are. But again, you're going to know best what those daily activities are that you're no longer able to do. Ideally, though, it's not waiting until you are so disabled that you can't do anything, because you will get better from surgery, but the more pain and the worse function you have before surgery, the more likely you are to not have a great response from surgery. You will get better from surgery, but the more ground you have to make up, the harder it is to get back to the level of activity that you would ideally like to have. So operate on people only because their x-rays show they have arthritis. We won't operate on people that have symptoms. But it's that fine balance of deciding when you're having enough symptoms that you want to go through arthroplasty, but again, not waiting until you are so disabled that recuperating from surgery is going to be extremely challenging. The type of recovery that you're going to have depends on what joint's being replaced, what kind of arthroplasty that you're having. There are a variety of ways of doing the arthroplasties. Usually by 3 months, people are doing pretty well from their arthroplasty, but we really don't know what their final function is going to be, usually at about a year, and that gives us an idea of how well they're going to be doing. Next slide, please. So again, the decision to undergo surgery for arthritis is a personal one. It's important, as with any other intervention, to talk about risks and benefits. So ideally, surgery would lead to an enhanced quality of life. It will help get rid of pain. It's going to improve function. But like any surgery, there's no surgery that doesn't have any risks associated with it. There is a risk of infection. That risk is extremely low. Most studies will cite somewhere between 2 to 4%. So, if it's you, it's 100%. But, overall, the risks are extremely low. I would say limited success with a question mark, because it's not the procedure that's the issue, is what you're bringing to the procedure. And so, again, the more pain you have, the worse function you have. The other joints that are involved, if you have other comorbidities such as depression or anxiety that are not being addressed, all of those can impact outcome. Women tend to have worse outcomes after joint replacement surgery, and there are a variety of things that we used to think that maybe the implants didn't fit women, or they're having more inflammation, or they're reacting to the metal that's being used. But more recently, we've looked at women, especially having knee replacement surgery, and compared them to men. And what's been found is that the primary difference is preoperative or before surgery, pain, function, and other health conditions. All of those are things that we can address by appropriately timing surgery and making sure that someone is getting a thorough evaluation and is working closely with their healthcare professional. For any joint replacement surgery, there's always a risk that what's put in gets loose. That usually is going to take some time. That's several decades down the road. It happens sometimes earlier in some people than others, but that's an area of arthroplasty that's continuing to be looked at. How do we try to limit the risk of the implants getting loose? Next slide, please. So thank you very much for the opportunity to speak today, and I look forward to the discussion.
Thank you, Dr. Templeton. So the next little bit, we're going to talk about what does collaborative effort for your OA care look like. Today, this webinar was kind of a collaborative effort between the Osteoarthritis Action Alliance and the Arthritis Foundation, but there are other universities and hospitals that also, can collaborate in your care. A few examples here are the UNC School of Medicine or the University of Kansas Medical Center. There are many ways you're going to collaborate there. So we'll go to the next slide and talk about that a little bit more. So really what we're seeing here is that there's a lot of things that go into osteoarthritis, and no one can tackle OA alone. So it's going to impact diverse communities and require a collective approach to address challenges. So, from a healthcare provider's perspective, they're going to diagnose, treat, guide patients through their OA journey. They're also going to collaborate with other professionals for comprehensive care, like Dr. Nelson and Dr. Templeton for, a patient living with arthritis. Like personally, I work with my rheumatologist. I also work with my primary care, and you kind of have your doctors kind of team up with you to make sure you're getting comprehensive treatment. As a patient, and I can speak to this, you want to actively participate in your care. You want to follow your treatment plans, stay informed, advocate for your needs, and really, really be an active participant there. Other ways that this kind of impact the people in your life, your support systems, your friends, your family, caregivers, they all play a vital role in supporting patients through daily activities and their emotional well-being. And I think a lot of us can speak to this, that having a community around you to support you and be there with you is extremely helpful, right? So how do we do that? We engage communities for better outcomes. So first, you're going to have diverse groups and organizations. Community groups and advocacy organizations can raise awareness, provide education, and connect patients to resources, kind of like what we're doing here tonight. Partnerships for progress, collaborations with researchers, insurers, policymakers to improve access to care and fund innovation, right? The only way that we move forward is if all of these groups are partnering and working together. And then ultimately having a unified goal. Patients, providers, communities can advance solutions for osteoarthritis, ensuring that no one is having to do this alone. And we have a little quote from Dr. Templeton at the bottom: "Together we can," right? And that's what this is all about. So with that, we're going to transition into our Q&A period here, where both of our wonderful speakers and myself will answer some questions. So I'm going to stop sharing my screen and we'll get into that. Okay, let's start. Okay, so this first one is for Dr. Nelson. Can RA contribute to the development of OA? What's the difference?
Great question. So rheumatoid arthritis is a particular kind of much more inflammatory arthritis, meaning that the immune system is more involved and people often have autoantibodies and reactive tissues within their joint. And RA is more of a systemic disease. So RA can affect the eyes and the lungs and a variety of other organ systems. So in that way, they're a little bit different. But people who have rheumatoid arthritis, or really any of the more inflammatory types of arthritis, psoriatic arthritis, gout, etc., can develop osteoarthritis. We used to call that secondary or post-inflammatory. All these things kind of get batted around, but essentially those joints are not normal. And the response of the body to try and heal the joints and stabilize them results in changes very similar to those of osteoarthritis. So you can absolutely have both. You can have RA and then primarily OA, even after the RA has been managed, or you can have osteoarthritis alone. So they're different, but can live together and complicate our lives as individual and dual entities, unfortunately.
Our second question is for Dr. Templeton. Is it true that surgery will make your joints worse? I've heard horror stories, says this listener.
Now, that's a great question. And I think for any procedure, any surgical procedure, there are going to be horror stories because nothing is perfect. The main risk, though, that you run into with having joint replacement surgery is infection. And that's typically some of the horror stories that you hear. But again, the risk of infection overall is extremely small. When it happens, there are ways to address it, but it requires more surgery and long-term antibiotics. So it's a huge deal when someone gets an infected joint replacement, but it's extremely unusual. We do know, though, that some people are at greater risk of developing an infection in their joint replacement. Those are people that with very high levels of obesity, people who smoke or vape, people with diabetes that is not currently being controlled. And so when you talk to your healthcare professional, if they do start talking about joint replacement surgery, if you have any of those risk factors for infection, those are all going to be addressed ahead of time. Because again, we know that people that are at greatest risk, it doesn't mean that if you don't have any of those, you couldn't get an infection, but it would be extremely unusual. So we try to address as many risk factors ahead of time as we can, even focusing on things like nutrition to decrease the risk of something getting infected. So that's, I think, of the main things that you hear about when a joint replacement doesn't go well. Again, there's always a risk that something is going to happen, but those are all extremely unusual. The joint replacement surgery has been identified as a procedure that has had the greatest beneficial impact on people in this country, because it does get rid of most of pain, allows people to be more functional, let them get back to their more normal activities. So you can hear horror stories, but that's why you need to talk with your primary care provider and your surgeon in depth ahead of time to know what to expect and to understand some of the risks, but again, understanding that the risks are small. But we do know, again, that there are risks, and so that's why there's ongoing research into other ways that we can address OA that maybe it doesn't involve arthroplasty. But those studies are very, very early in the development. You'll hear about things such as stem cells or regenerative medicine. Those have not been proven to be beneficial at this point in OA. But if there's a way that we can make those beneficial at some point in the future and not do arthroplasty, that would be great. But science is not nearly there, not nearly to that point yet.
Okay. This third question is for Dr. Nelson. How do you diagnose OA? Besides symptoms, is it through blood work and levels of C protein levels?
Yeah, so generally the diagnosis of osteoarthritis is what we call a clinical diagnosis, which means that your doctor is going to ask you a bunch of questions about your history and do a really detailed physical exam of your joints. And a lot of those, sometimes that's all we need. We get the clues we need from that. So we can tell if the bones are enlarged, if there's crepitus, or that kind of popcorny sound that you get when you walk up and down stairs. We can see which joints are involved and kind of patterns of joints across the body. And that's often all we need. If there's any question in the clinician's mind, sometimes we'll do labs, but those are more to rule out other things. So in general, there are not blood tests or anything that's diagnostic of osteoarthritis, but we might do a rheumatoid factor and CCP to rule out rheumatoid arthritis, or C-reactive protein and a SED rate to make sure it wasn't more inflammatory than we thought, because generally OA is just mildly inflammatory on blood work. Imaging similarly is usually not needed. A lot of people will get imaging, particularly plain x-rays, but a good H&P often is all we need for that. And certainly more advanced imaging is not required. So you do not need an MRI to diagnose osteoarthritis and really should not be getting one for that purpose.
This next question is for me. As a patient, what are some self-care actions that you take to cope with your arthritis diagnosis? And that's a really great question. And it can vary for everyone. So some things I personally do, with psoriatic arthritis being an inflammatory arthritis, it works a little differently from osteoarthritis, but a lot of the things I do would be the same things that someone with osteoarthritis would do. I am all about physical therapy. My physical therapist and I really work as a team to, keep me moving regardless of the limitations that I'm facing that day, especially with an inflammatory arthritis that kind of moves around. So sometimes it might be my ankle, sometimes it might be my wrist. So she's really great at working with me to keep me moving, to, keep me as mobile as I can be. There are some other things that I kind of do at home. If I'm in pain, I ice, heating pads. I try to do stuff like that. As our experts have discussed, really trying not to do too much NSAIDs. So personally, if things are really bad, I will kind of add that into kind of my treatment here and there. But I really mostly try to stick with like the heating and the icing. Some other things that I do to cope with the diagnosis bit is just personally, I do regular therapy with a therapist. It's been extremely helpful to have someone to talk to. And I know that's not accessible for everyone, but if it is something you can do, I would, really encourage it. It's a hard diagnosis to have. There's a lot of feelings, a lot of grief, sadness, anger at not being able to do things. And, so sometimes you really just have to kind of reframe and try to see, okay, well, this is, the life that I am living right now. How can I make the best of that? And how can I work with what I have? Some other things too, is I really try to make sure that I'm doing everything I can do nutritionally to help support my body. Because, with arthritis, your body's going through a lot, right? So I'm personally try to limit the potential comorbidities that you are more susceptible to. So I'm doing everything that I can, diet, trying to exercise as much as I can to hopefully limit my risk for some of those things as well. And then just being able to be open with your friends and family to tell people if you're having a rough day, or maybe there's something you wanted to do and you really don't think you're up for it. Just, being honest with people. I think it's the more honest you can be with other people and yourself, it'll help you to cope with what's going on. So I hope that was a helpful answer. I know that can be very personal from person to person. So I obviously don't speak for everyone with arthritis there. And then we'll kind of shift into another question for Dr. Templeton. Expand on your thoughts about physical therapy. Is it truly helpful?
And I would also expand on your comment, Angela. Yes, it is. I think physical therapy is a great modality, or occupational therapy if you're dealing with something that's in your arms. Physical therapists sometimes do arms and sometimes just do lower extremities or legs. The physical therapy is a great modality to help improve your range of motion. They can work on careful strengthening exercises. So again, make your muscles stronger to help support your bones and joints. They can also help you with adaptive equipment if you need that, learning how to safely use a cane if you need that to help get around. So yes, physical therapy is a great modality, and often once you finish a course of physical therapy, they will develop for you a home exercise program so that you can continue with the exercises that you've worked on with a therapist. And I would say do that in addition to other physical activity, whatever sort of activity you can tolerate. If you're having a lot of issues with joint pain, then things like swimming or a stationary bike are usually good options to help not only maintain your muscle strength and your range of motion, but also helps overall with your cardiovascular health. So I would say a combination of physical therapy and exercise, but with the therapist helping you adapt exercise and find an exercise that works for you.
Then our next question is for Dr. Nelson. I have OA and diabetes. Is there a good diet to help both areas?
Yeah, so osteoarthritis is associated with a lot of comorbidities. I was just answering a couple questions in the chat. So cardiovascular disease, diabetes, some types of liver disease, these things all share this kind of low-level inflammatory metabolic background, and the risk factors are very similar for a lot of them. The diet issue is interesting, and there were several questions in the chat about this. There's not a specific diet or a specific nutritional component to avoid or add. It's more about eating a healthy, well-rounded diet, so like the Mediterranean diet or the DASH diet or any of these that are good for cardiovascular disease or good for diabetes are probably also good for osteoarthritis. There have been studies of specific nutritional components, and those have not really panned out to date. I would note that if you find a trigger that makes your arthritis worse, then that's real for you. And it really doesn't matter what the population health studies show. So, if you're triggered by milk or sugar or something, you can certainly avoid certain things, but you just don't want to do a really restrictive diet because those are not likely to help and really haven't been shown to have any impact on arthritis.
Okay. And then we also had a question for me about why should our participant join a Connect group, and we are going to talk a little bit more about that later on. But the Arthritis Foundation offers Connect groups, both some that are in person, local areas based on state. There's also national Connect groups that are more based on a particular population or a particular type of condition. So like we just discussed at the beginning of the presentation, I'm a facilitator for the Psoriatic Arthritis National Connect Group. So we meet virtually on Zoom with folks calling in nationwide. And something that I always tell people about Connect groups is that you need support, right? And a lot of people living with arthritis, maybe don't have the support in their day-to-day life that they would like to have. And it's really beneficial, I have found, and a lot of our participants have found, to get to talk to people who know exactly what you're going through, right? Like very, interesting specific symptoms that someone with psoriatic arthritis will have might sound totally nuts to your friends or your family, right? So it gives you just a support group. It gives you, people to bounce off treatments with, as we're not medical professionals, but we can share experiences with medications, with modalities like PT and OT. So I would just encourage anyone to join a Connect group because, they provide a lot, like support, resources, education. There's a lot of good things about them. And so, that kind of wraps up most of our Q&A, but so I'm going to reshare my screen. And we are going to, let's see. So, okay. So if you have additional questions, we really encourage you to use the Arthritis Foundation's helpline. You can see here the contact information for that. If you want to volunteer, you want to better understand your disease, you need help with interpreting your insurance, and you want to connect, you're looking to get involved and do advocacy, we can point you in the right direction, right? Either a volunteer like myself or someone, Arthritis Foundation staff who man the helpline and the phone and the email. So please take advantage of that if you'd like to. Some additional support resources. Like we said earlier, we have upcoming events. You can find those at arthritis.org/webinars. So the next one is going to be Thursday, January 23rd, weighing your options, managing weight with arthritis. So that's another great one to tune into. An example of one of our other Connect groups, and they're branded as Live Yes Connect groups on the website, is our newly diagnosed group. That they talk about self-management and lifestyle factors. So they're going to meet January 9th. So our newly diagnosed group is folks with all types of arthritis who have just have the commonality of just being newly diagnosed. There's also the Live Yes podcast, which the Arthritis Foundation puts on as well. Some additional resources from the Osteoarthritis Alliance is Stand Up 2OA Facebook group. Looks like they have over 21,000 members. It's a safe place where you can get into that group and ask questions and share your struggles with osteoarthritis. And also they have a patient resource portal, Living Better with Osteoarthritis, that has videos, educational materials, and other tips on managing osteoarthritis. So with that, I would absolutely like to thank our experts for joining us today, Dr. Nelson and Dr. Templeton. These types of webinars would not be possible without our awesome experts who give their time to help answer questions and educate us. And I would just like to thank all of you for tuning in and asking thoughtful questions. And for anyone who's watching this in the future, we would love to have you guys at any webinar and to get involved, to volunteer. So I would just, like to thank everyone for tuning in.